Good morning or afternoon, depending on the time zone that you're in. This is Mark McClellan. I'd like to welcome you all to today's Accountable Care Learning Collaborative webinar on strategies for physician engagement in accountable care. We've got a couple of great presentations coming up, a little bit of time for a discussion at the end, and as usual, we're going to have a short policy update on accountable care at the beginning. So I'd like to get started right away, and if we go to the next slide. Just want to start with a couple of housekeeping reminders. You all should be muted right now when you're called in, but please do make sure your phone is on mute. You can do that one of several ways. The easiest is probably just pressing the mute button on the phone. If you do have a question or comment later, please unmute at that point, and we'll have a chance to hear from you directly. We do want you to submit questions or comments at any time along the way in this webinar. You can do that using the question or chat box of the GoToWebinar window for those of you who are logged in on the computer. And when we get to the time, if you're not logged in via GoToWebinar, you can also just unmute your phone and ask a question or let us know you have a question at that point. Next slide. We have, as I said, several things that we're going to try to cover today. First is a few accountable care updates from a policy standpoint, and then we're very pleased to be joined by Grace Hines, Corporate Vice President for System Integration at Sentara, who will talk about some innovative work that Sentara is doing on strategies for physician engagement as part of a clinically integrated network, an ACO program, and then by Dr. Bryan Oshiro, the Chief Medical Officer at Health Catalyst, on some of their strategies for identifying and exploring effective engagement of physicians, and then again some time for discussion at the end. So next slide, in terms of updates, the next slide, the first topic we want to cover, which is a recent announcement from CMS about the Comprehensive Primary Care Plus pilot program at CMMI. This came out a couple of weeks ago and is CMMI's biggest and I think boldest effort yet around supporting a primary care medical home model. You all may be familiar with the Comprehensive Primary Care Pilot, which was launched several years ago. This one, I think, can be viewed as a reflection of the early learnings from that pilot, which you may remember was a regional effort with some bonus incentives and payment tied to performance at the regional level in conjunction with upfront per beneficiary per month payments and supports for primary care practices to deliver better care. The effort was a multi-payer, or is a multi-payer initiative. It's still ongoing in a number of regions around the country. If you put that together with this one, CMS clearly intends to reach a large part of the primary care physician, primary care practice population. This one and the announcement highlighted an aim for as many as 5,000 practices, 20,000 doctors, 25 million patients. Going on to the next slide, maybe more than 20 regions around the country and some direct engagement with health information technology vendors. This reflects CMS's commitment to try to partner with other payers, states and commercial payers, as was done in CPC. I think one of the challenges here in getting to 20 regions is that this proposal is on a pretty tight timeline with an intent to try to get the commercial and state partners lined up as soon as in the next 6 weeks, at least at the level of a commitment in principle. So they may not reach all of those 20 regions, but again, very bold effort intended to be a significant impact and size, enough size to really get a more complete assessment of the impact of these kinds of models. CMS is also going to work directly with the health information technology vendors. I think a reflection of some of the challenges that arose in the CPC program in terms of IT support, while electronic records were present in all of these practices, maybe not as many usable tools and effective data sharing to support better primary care medical homes as CMS and the practices would have liked. So that's going to be a more integral part of this effort. The payment model is similar to the CPC initiative in that it has an upfront per beneficiary per month payment. There are 2 tracks in this program. Different from the first CPC program is that the payments will be more tied to the risk level of the patient. So in some patients with complex needs in track 2, the payments can be as high as $100 per beneficiary per month, with averages more in the $15 range for track 1 and the $28 range for track 2. In conjunction with this upfront care management fee, the practices are expected to implement a number of capabilities related to care coordination, access to services, including after hours, practice capabilities in terms of providing data and tracking on patients, and of course reporting on performance measures. In the addition to this case management, the care management fee, practices will also get revenues that are more like the traditional sources. In track 1, it's the regular Medicare fee-for-service payments. In track 2, the idea is to shift to more of a comprehensive primary care payment, like some of the more capitated primary care payment models that have been implemented by commercial and some Medicaid plans. So that's an even more capitated version of primary care reimbursement than the PBM, the per beneficiary per month payment alone. And then on top of that, the third component is incentive payment based on the performance measures that are reported. This could be as high as $2.50 per beneficiary per month in track 1, $4 per beneficiary per month in track 2. The payments are prepaid at the beginning of a fiscal or a program year. The idea is that if you put the money there in an account, it's going to have more of an impact on practices wanting to keep it than if they don't have that money at least available in principle up front. So I think a lesson they're trying to apply from behavioral economics. But you don't actually get to keep the money unless you meet the quality and utilization thresholds. And with the health IT support that's envisioned in this effort, the idea is that practices would know more accurately how they're doing relative to these incentive payments as they go along. So on to the next page or the next slide. But just one more point before we get to the Healthcare Payment Learning and Action Network about this. One of the issues that has come up with the CPC Plus program already is questions about how it interacts with programs, primary care practices that are participating as accountable care organizations. As I think you all know from the tracking that we've been doing, close to half of all Medicare shared savings ACOs and even some of the ACOs in track 2 of MSSP are primary care practices or smaller groups of physicians, some cases aggregations of some very small practices that otherwise would be eligible for potentially participating in this program. And one of the challenges that have arisen for some of these practices in the Medicare ACO programs is not having access to the kind of PMPM upfront resources that the CPC program would provide. So CMS has already gotten a lot of feedback that perhaps one avenue to pursue in conjunction with this model is proposed as an option for ACO primary care practices to participate. This would require them to calculate shared savings net of the payments that are coming in up front and any other incentive payments that they receive. But that is an avenue that you could see develop over the coming weeks as this program gets finalized, and something that we'll be tracking closely as well for many primary care groups that are trying to take on overall population accountability for costs and outcomes, at least in terms of upside savings. This kind of program could be valuable. Many commercial plans and Medicaid managed care plans have done exactly that kind of combination, the PMPM and additional practice management support up front, linked to an expectation about actual accountability for overall costs on the back end, rather than just the payment incentives as is envisioned here, the PMPM-based adjustments on utilization and quality measures. So that could be an evolving feature of this model, especially since many commercial plans are moving towards more overall population accountability to encourage more focus on care coordination across the spectrum of care. In fact, if you look at the early results for the CPC program, some of these were reported just recently, earlier this month, in the New England Journal of Medicine. The results showed some positive impacts in terms of improvements in quality of care and reductions in cost of care, particularly around some of the primary care office-based services, which are clearly being replaced by remote patient monitoring, care coordination, and the like. But overall, not net savings because of a limited impact, at least so far in the first couple of years of that CPC program, limited impact on other non-primary care costs. So this is why there's been some interest among many commercial payers in linking these primary care initiatives to overall accountable care payments. And I think you should expect to see some more developments happening both in the CMS CPC Plus program and more generally along those lines, and we'll certainly keep you apprised. The other brief update for today is on the Healthcare Payment Learning and Action Network, which just completed its two-day summit in Washington, D.C. Yesterday. As you all know, I'm a co-chair for this public-private collaboration involving CMS and a wide range of other groups that we view as very complementary to the work of the ACLC, which is focused less on the specific next steps of payment reform and more focused on how to support healthcare organizations in implementing payment reform models and doing well as they take on risk and accountability, helping them do that successfully. So very complementary. Just as a reminder that the Learning and Action Network is focused on getting to some practical steps to accelerate the adoption of new payment models, particularly models that have population-type accountability, accountable care organization-type models, episode payment models that bundle payments and create accountability, both outcomes and total cost of care for particular types of patients and services across all of the providers involved. The practical focus for the Learning and Action Network has included, as described on this slide, defining what exactly we mean by alternative payment models, and the Learning and Action Network has a framework for that, and then identifying some best practices and broad-based recommendations to drive more effective adoption of alternative payment models, something that Lou Sandy from United has called getting the componentware well-defined. So around areas like features of episode payments, features of population-based accountable care organization-type payment reforms, benchmark methods, and the like, promoting more alignment around best practices between CMS, private sector, Medicaid, and state plans to, so that people aren't reinventing the wheel and providers aren't being pushed in different directions, as well as developing more evidence on which payment reforms are working in which settings and expanding those. If you go to the next slide, and just also make a note while we're doing that of the website where more information on all of this is available, hcp-land.org. The land work products are including a number of papers and other resources that are complementary to the work that we're doing in the ACLC. The first work products have been around a consensus framework for thinking about alternative payment models, and now a national effort to track how we are doing. CMS is already reporting using this framework. You may have heard earlier this past month, CMS announcing that they had reached their 30% goal of payments in systems that include links to population-based results. These significant alternative payment models. The main component of that was ACOs. We'll talk more about where that's all headed on an upcoming webinar. But beyond that, the LAN has released draft reports on best practices for patient attribution, for financial benchmarking in population-based payment models, for elective joint replacement episodes, for maternity episodes. Coming soon is chronic cardiac care management episodes, and recommendations and best practices around data sharing. And these do reflect a kind of consensus approach between participants in the LAN, CMS, providers, private payers, purchaser organizations, and patient groups. And so I think you can expect these to be an indication of where CMS and the field are headed in terms of these details of payment reforms and the technical support like data sharing methods for those payment reforms. So more coming there, and we want to make sure that you're aware of the resources. So that's my overview and updates. Coming soon in terms of updates will be MACRA and next steps on ACOs and other accountable care payments in light of that. The MACRA core proposed regulation supposedly has just cleared OMB, which means it should be out for public release pretty soon, though it's always hard to tell exactly. And we will be providing an update for you on some of the key features of this major physician payment reform implementation and its implications for moving towards accountable care. But right now, I'd like to turn to our main content from the day. First, we're going to hear from Grace Hines, who's the Corporate Vice President for System Integration at Sentara. She specializes in executive leadership for the design and implementation of Sentara's Transformation of Care Strategic Imperative. She's the president of the Sentara Quality Care Network and has responsibility for overseeing both the implementation of their bundled payments for care initiative and their Medicare strategy more broadly, involving accountable care and payment reform for Sentara Healthcare. She's been with the company for quite some time and has worked in radiology as vice president of operations for a community hospital, as vice president for cardiac, vascular, and transplant services at Sentara's flagship hospital, Sentara Norfolk General. Before all of that, she began her career as a registered radiology technologist and also received her MBA from where I'm talking to you from today, the Fuqua School of Business at Duke University. Grace, very pleased to have you with us today.
Thank you. So let me give you our perspective on physician engagement as it relates to our Sentara Quality Care Network. And I would believe that many of the folks that are listening to this would agree that there's so much variation in our organizations as it relates to CINs and accountable care, that this opportunity for me to present this information might offer to somebody maybe one or two nuggets of things they can take to their organizations, and then certainly subsequent presentations I'm very interested in as well for that same reason, so that what we can learn, because there is no textbook written yet for how we need to do all of these things. So very pleased to be part of this organization and have this opportunity. Next slide. So this is just a little bit about Sentara Healthcare for those of you that don't know who we are or where we are. We are primarily in Virginia, although we do have hospitals and other facilities in North Carolina. We are fully integrated, and we do have our own health plan, which is called Optima, which is our insurance product, and we have 450,000 members in that, which spans everything from Medicaid to commercial to Medicare Advantage. Next slide. Okay, so the Sentara Quality Care Network got started about 3 to 4 years ago, and in Virginia, we are still primarily a fee-for-service market. All of our providers, except for a very few providers in Medicare Advantage, all of them are still on fee-for-service payments. We really haven't had a lot of activity as it's related to capitation, and certainly at the time that we got organized to put this network together, we really didn't have anyone knocking at the door from the employer or the payer perspective in terms of wanting to have a new product. So this whole network was built around the premise of the industry moving from volume to value, and that we wanted to be a part of readying this community for that transition and to provide opportunities for our physicians to be able to participate in this transition before it became a mandate, and so that we could learn and really put our infrastructure together. We cast the net very asking any of the physicians in our markets to participate, which resulted in a pretty large network right out of the chute. We have, right now, we'll probably be topping over 3,000 members in this network in the next couple of months, and we're in different markets, as you can see on that map, and that geography from the right far to the left is a 4-hour drive. So we not only have the challenge of managing a large network in terms of a large number of providers, but we also have a challenge of managing a network that goes across that type of geography. You can see that it's all of the Sentara hospitals included, as well as Children's Hospital, which is an independent hospital system in Hampton Roads. They are also very involved, which has been extremely important, especially for our commercial population, given the number of pediatric patients that are in the commercial population. And we have all of those facilities have a number of outpatient sites. The vast majority of our physicians are independent, and that creates a set of challenges on its own. One that you all are very familiar with, the challenge of IT systems, and we probably have 50 to 55 different EMRs across all of these practices, although we've standardized to Epic within our employed physician population, and the Epic capabilities are wonderful, but it does not span across and does not have capabilities to the vast number of providers in our network. Next slide. So this is what we promote ourselves as being about. We really want to be that catalyst for change, to be able to bring greater value for employers and better experience for those individuals that work for the employers. Our initial efforts have really been all around commercial patients. We've made a decision to not get involved as of yet in the CMS Medicare Shared Savings Program. So we are, at this point in time, all of our contracts, with the exception of a small Medicare Advantage contract, is all for commercial payers. Next slide. We try to get this message across to the employers to try to understand, well, what's different about this network compared to what we've been doing with your insurance company and other insurance companies. And certainly the relationship between the employer and the insurance companies is extremely important in terms of what they have been able to do to manage care over the years. But the one thing that the Sequin providers offer, as well as any providers within an accountable care or clinically integrated network, is the knowledge and the know-how of the providers in terms of how to make a difference, how to manage specialized staff, and most importantly, we believe the ability to influence each other in terms of best practice and how to improve performance, as well as influence the patients in terms of what capabilities they need to be seeking in terms of their medical care and what is appropriate for them at a particular point in time. So we believe that influence piece by a group of dedicated and committed doctors to a defined population is something that the insurance company has not been able to bring to the table, and something that the employers on their own have not been able to bring to the table. But it doesn't negate the importance of the role of the insurer or the employer. Next slide. So we embrace the principles of clinical integration, and for this, we don't need to go down all of this, and these are all things that are, all the great motherhood and apple pie things that we all are very committed to and want to make happen. But the question is, how do you make it happen, especially in a market like ours where when we got started, we didn't have a lot of individuals knocking on our door looking for a new payment model, and we were working to convince our physicians in our community that it was time to get ready for what we believed was about to occur, and about to occur meaning in the next couple of years. Next slide. So we have, a number of structures that I will go over just quickly in a minute regarding physician leadership, which is an essential component of clinical integration. As we all know, you have to have a physician to meet the requirements of the FTC. But it's more than just physician leadership. It's really about physician engagement of the network and a large number of providers in the network. So in the early years that are being focused on developing the CIN and the ACO infrastructure, the data systems, the quality metrics, the integrity of the data, and all of those things that are challenging for us, and yet you don't have a contract to be able to say to the physicians, here's something tangible. How do you engage the membership? And we sort of thought a bit of it as a chicken and egg sort of situation. Absent of physician engagement, the goal of attracting commercial insurance is, and any insurer is extremely challenging. But absent attracting commercial insurers, the goal of engaging physicians is challenging as well. So it's like, what comes first, the chicken or the egg? Do you get the contracts, and do you then say to the doctors, we have the contracts, but then you've got to set up all the infrastructure? And again, with the folks that are on this call, you understand, I think, very well what I'm referring to. And so what we decided was that we needed to come up with ways to engage the physicians and to bring forward what I'll go forward with on the next slides. Next slide. So this is our organizational structure for CINACO and our board of managers and all the various committees that we have, similar to what most organizations have, from the clinical performance committee over to that contracting committee. We also have local regional service organizations because of the geography difference and because there's some issues that we need to deal with in terms of network size, network capabilities, and local sorts of issues. We have what's called local regional service organizations, where the work that's done by the governing body then trickles down to those organizations for implementation at the local level. And we also have primary care collaboratives, where we actually have primary care doctors that voluntarily join these collaboratives to do the learning and the data sharing, and I'll go over in a bit what those collaboratives are all about. But even with that organizational structure, we have 126 physicians that are on the committees that are the structural committees and the ones that are listed in our operating agreement, and that's less than 5% of our membership. So getting physicians engaged is a big challenge for us given the size. We've got 126 engaged, but how many folks those 126 people talk to in a busy day of a practicing physician's day is probably a fairly small number. Next slide. So what we decided to do was to start by creating value for the CINACO providers, that if we could create value for the CINACO providers through their lens, through their things that are important to them, we would then be able to develop the capabilities that are needed for the network to be able to create the value for the purchasers, whether it be through per member per month care management fees or shared savings. And so here's a list of things that we put together, and I'll go over a little bit about each one on the next slides. But for CME, Part 2 and Part 4, recertification, we've done what's called innovation calls, which are education calls, helping the physicians get recognized as patient-centered medical home, those that wanted to, PQRS reporting, education about all of the things that, is coming out of the Affordable Care Act. And then we also have a program that is geared towards practice administrators to keep them educated. And this is especially valuable for us because we have so many independent providers and so many independent providers that are primary care providers in the network that have really been far removed from the health system for quite a while since we started using hospitalists to manage patients in the hospitals. And these are the practices that are the most resource constrained, and they're also the practices that probably have the least amount of information that they can that they do access. It's not that it's not available to them, but running a small practice is a job unto itself without really having to go out and gain all the information about what's going on around them in their industry. And so we thought it was pretty important for us to be able to offer to physicians those things that could add value to them in their practice today so that they could then see the value of being part of our CINACO network. Next slide. So on the CME thing, some of the topics that were relevant to our accountable population, we found out when we started looking at our commercial population that headaches was the most, that was the highest volume for treat and release from our emergency rooms for the management of headaches and headache pain. And so we were able to put together an education session specific about that. And what we're trying to do is to kill two birds with one stone, find things that are important for the physicians in the network as well as find things that are important that relate to the populations that we will take accountability for. And because we have a health plan, we're able to get information from the health plan about utilization and the types of services that commercial populations frequently use. So by finding that headache situation and coming up with a pathway for how these patients could be better managed and finding out that a lot of these patients were not on preventative medications, we were able to put together CME education, and we had a very, very large turnout of our providers to be able to come and learn about headaches while at the same time getting their CME credits. We also came up with a way with working with our folks that do education throughout the system and through the health plan and through our medical group to look at maintenance of certification for Part 4 for family practice, internal medicine, and pediatrics. And we were able to focus on diabetes, being the largest diagnosis for any population that we are looking at, and to really be able to look at how we could reduce that A1C less than 8 from the baseline that we started at. And so we have had very good success with managing this diabetic population, which helps us for our stories to the employers regarding how well we can do with managing diabetes, while at the same time being able to provide physicians that needed their Part 4 certification a way to participate in a quality improvement project that would give them what they needed to complete that certification. Next slide. CINACO provider-to-provider education, we do that through innovation calls. We're doing monthly lunchtime webinars, and these are both for primary care physicians as well as specialists and practitioners. And we try to link these where we can to things that are relevant to the populations that we have and will have responsibility for. And these are some of the examples of the topics are listed here for you. You can see that one of the things that we do have talked about and educated the physicians about is what's going on with Medicare and what's going on with Medicare shared savings programs and why we've made the decision that we have, not specifically relevant to CINACO as it's organized today, but a very important topic for physicians to understand, again, emphasizing the importance of this to independent providers that really don't have as much access to this information as our employed physicians do that are part of the network. The practice managers really love these calls as well, and we have the opportunity for them to ask questions. We also actually do practice manager meetings once a month, either through webinar or face-to-face meetings, to provide them education and so the tools that they'll need to be successful and to help educate their physicians regarding this move from volume to value. Next slide. PCP collaboratives, as I said earlier, this is a voluntary Nobody gets paid to come to this meeting except the chair of the meeting. It is very much voluntary, and what we have found is that we have really hit on something extremely important in terms of being able to bring the independent providers together with the employed providers, with the notion that they are there to help teach and learn from each other. We share our metrics and our performance, and we have regular dialogue between these providers, ways to improve performance. Folks that are, on to the right of the bell curve, what is it that they have done to get the results that they have achieved? And so we don't have to do a lot of asking people to attend. We often have standing room only attendance at these meetings because it is focused primarily from the view of the primary care physicians, where we are in terms of with activities within the network, but things that they need to know and that they can learn from each other. We also helped our primary care providers who were interested in getting patient-centered medical home recognition, and we did that through the collaboratives. We provided physician education, office practice education. So we had practices that had already gained patient-centered medical home designation come in, share their experiences, knowledge, and staff, and we actually put together a binder of information for folks to be able to take in terms of how to complete their applications if in fact they wanted to complete their applications for patient-centered medical homes. And we've had many of the independent practices that have pursued that now and our patient-centered medical home recognized, but likely would not have been possible had they not had the infrastructure and the support from their colleagues in the primary care collaborative. And then we also did PQRS reporting. We're not doing that now for the physicians, but we did offer that for the physicians, and especially educating them about PQRS, and we used our IT capabilities to be able to take the information because we were using McKesson, that was a registered provider with CMS, to transfer that information to CMS for practices to meet their PQRS reporting requirements. And we found when we started this, we had a lot of independent practices that weren't doing any of this at all and were really on the road to penalties, and so we were able to step in and help them be a successful practice, because the success of our primary care physicians and other physicians in the network really drives the success of the network and the success of our health system. So we want successful providers, even if they're not part of our system formally as an employee, in the community, because that's what's going to make us successful overall. Next slide. Affordable Care Act and the SGR repeal, all of the things that just were previously talked about are the things that we include in our education, and as you also heard, this is still a work in progress, but we need to make sure that physicians understand what's real today, what still has to be finalized, and we'll know more through comments that are made over the summer, and then what will be finalized with final rules on some of these initiatives in the fall, so that they're making decisions based on what's fact and not fear. And the fear factor can be pretty big, especially for a primary care physician that could be looking at as much as a 9% reduction in fee-for-service payments if they're on the track that is, reward penalty track versus an alternative payment model track. So we want to make sure that they have good information at the right time so that they can make informed decisions and not make a decision based on the fact that they're fearful if they don't do something right now that it's going to be a problem to them, this time next year or later on. Next slide. So once we have engaged our employer and payer contracts and we've got those secure, now we are working on engaging physicians to achieve defined results. Over the last couple of years, we've moved from 33,000 attributed lives to our network to almost 90,000 lives that we have this year, and we're anticipating and have got a lot of conversations for January 17th membership. So our membership is growing very, very strong. We are looking at clinical metrics, and from our one of our large employers, we do have an incentive pool just based on clinical metrics, but in 2017 we will be moving to managing total cost of care, being able to impact that healthcare spend trend and to create shared savings as well as performance on the quality metrics. And we feel that we've got a lot more engagement now from the physicians to be able to join us in the work that's going to need to be done on these kinds of contracts, which is going to be very new work because of the work that we've done to them to date, finding ways to show them that we are there to make them successful. We want them to be successful even when it isn't tied to a contract. But now that it is going to be, our performance is going to be tied to contracts through total cost of care savings, we think the investment that we've made in helping these physicians be successful prior to now is really the right way to keep them engaged and moving forward. Next slide. So we now have network relevance to the doctors. It is very tangible. One of the biggest challenges we're going to have, as we all have within CIN, is data and analysis, making sure it's accurate, timely, and actionable, and what we're going to prioritize for opportunities and how we're going to align incentives. Now the rubber meets the road. We truly now are into value contracts, and we would never be able to do this if we didn't have a large number of our physicians very engaged. Next slide. And this is the last slide, just sort of the continuum as we see it in terms of physician engagement, starting with creating value for the provider to attract engagement, then linking engagement to the principles of accountable care so that you are killing two birds with one stone as often as you can, so that we're able to deliver value to the patients and purchasers of accountable care, to the providers, that they are looking to be accountable and really getting better results for them as it relates to quality and total cost of care. So I thank you for giving this time, and I think we'll do questions at the end.
That's right, Grace. Thanks very much for the presentation. I especially like the strategy around linking value to the provider to value to patients via the accountable care strategy that you're implementing. Putting that all together is not straightforward, and it's great to hear about the, your experience and progress and success in doing so. We are going to turn to our next presentation now. We've had a few questions, comments come in. We're running a little bit late. To the extent we don't get to those questions on the webinar, I might try to prevail on Bryan and Grace to help answer them briefly by email or on our online resources afterwards. But right now, I'd like to introduce our next presenter. Dr. Bryan Oshiro is the Chief Medical Officer at Health Catalyst. He's also an associate professor at Loma Linda University in California, and was the clinical leader of the first quality improvement initiative at Utah's Intermountain Healthcare back in the 1990s. He also was on the faculty of the University of Utah School of Medicine in Salt Lake City back then, and served as director for women and newborn clinical integration services for Intermountain. Dr. Oshiro got his MD from Loma Linda University, and subsequently was board certified in obstetrics and gynecology and maternal fetal medicine. Has been very involved in both clinical research and in quality improvement activities. So Dr. Oshiro, looking forward to hearing about your perspective from Health Catalyst.
Hi, can you hear me?
Pretty okay. If you can speak up a little bit more, that would be great.
Okay, let's go to the next slide. So just a different perspective. I think Grace's perspective was from the administrative view and so forth. I just really wanted to always bring up the point from the view of the physician. I've been living this life as either a clinical participant in this transformational process or one of the leaders within the system to help bring physicians along. And one of the things I've very much appreciated is that there has to be strong engagement and alignment of physicians to do this work, and yet how do we get them to be engaged? So, of course, all of us know that with the changing healthcare landscape today, that it really is incumbent upon the hospital systems and the physicians to really partner in moving forward because of the population health issues, the changing payment models, the need for quality improvement, and to really control our costs. And it's so critical for us to have a very, very engaged physician workforce. Next slide, please. So what is the definition of engagement? If you look at Webster's dictionary, it says that it's an arrangement to be present at a specific time or place. It's a period of employment. it's a pledge or a promise, it's emotional involvement or commitment. And how can we get to this level where there's really an investment of and by the physicians in the work that we have to do together? It really is about, if you want to sum it up, it is a relationship. It is building a culture. And a Gallup survey showed that if there was a true physician engagement, that there is actually 26% increase in productivity of the system over those systems that really did not have engaged physicians. Next. So I'm really speaking to the choir, but I just wanted to bring up some points. There was a nationwide survey that looked at 15 elements of physician engagement and looked at these particular elements. And they looked at it on a Likert scale of 1 to 10. And I just wanted to go over this study because I think it gives us a sense of what physicians actually think. And these are the questions that were asked. Respect for my competency and skills. Feeling that my opinions and ideas are valued. Good relationships with my physician colleagues. Good work-life balance. A voice in how my time is structured and used. Fair compensation for my work. Good relationship with non-physician clinical staff. A broader sense of meaning in my work over and above my day-to-day duties, a voice in clinical operations and processes, opportunities for professional development and career advancement, good relationships with administrators, alignment with my organization's mission and goals, working for an organization that is a leader in innovation in patient care, participation in setting broader organizational goals and strategies. Next slide. And so you might think that those are all probably easy to answer, and there's probably agreement between administrators and physicians, but these are what the physicians actually listed as their top reasons that came up. So this is an order of priority for them, or the number of responses that were positive. Respect for my competency and skills, and of course this really looks at what physicians do on a day-to-day basis, and indeed why they went into medical school anyway, is to take care of patients. And they also valued feeling that my opinions and ideas are valued. And so look at your own institution and see where physicians actually fit. And it's this first word in there, the description, feeling. So maybe you do value physicians' opinions and ideas, but do they actually feel valued? That's the important thing. Good relationships with my physician colleagues seems like a no-brainer. Good work-life balance. You know, in an era of when I trained, you know, we spent approximately 120 plus hours in the hospital, and that was just expected. And now with the 80-hour work week, our physician workforce is in a much different environment, and their expectations are a lot different. So the value that my residents today place on work-life balance is much more so than it was in my generation. They want a voice in how their time is structured and used. So when they have or are incorporated into a system in which they're expected to see patients every 15 minutes or every 20 minutes, there's no variation in the ability to change that parameter or dynamic and so forth, it really leads to low morale and really leads to poor integration. Less important, although they did say that these were also important, but less important were these three things: participation in setting broader organizational goals and strategies, working for a leader in innovation of patient care, and alignment with the organization's mission and goals. And that's sort of interesting, where you think we really want to be aligned with the organization's missions and goals. About 50% of these individuals that were taking this survey were actually the younger generation and so forth. And most likely they were more interested in building their own practice rather than working with the organization and understanding where they fit. But I think that this is an important thing, that it wasn't important, it wasn't high on their list. Next slide. So if they the physicians were asked, give me the top 3 picks. And these are what came out first. And first was good work-life balance. It's so important for them to be able to take care of their families. Half the physician workforce that's coming out now is female, and they are more attuned to having families, raising children, and so forth, so we have to be aware of their needs. And indeed, many of the young fathers, too, they're taking off time for paternity care as well. They want to be fairly compensated for their work. And, you know, we had this discussion, at least at my professional organization, as to the realities of the coming future and the uncertainties of reimbursement. And they're very much worried about how they're going to get paid and that they may not get paid for the work that they're doing. They value a broader sense of meaning in my work over and above my day-to-day duties. So they really want to make a difference. So a sense of what is the purpose of me working, not just the care necessarily of the patient, but overall, can I contribute? Feeling that my opinions and ideas are valued. And finally, a voice in how my time is structured and used. So if you look at this, it's really about their time and their autonomy as to how they can use and craft their time. And how can your organization fit into this? And if you look on the right-hand side, you can see that this triangle there, and that's Maslow's hierarchy of needs. And if we take care of the basic needs of the physician community and so forth, then they are able to then not worry about, am I getting paid, am I enjoying my work, and so forth. And if they can get those needs met, only then can you talk about and work towards that common higher goal, that higher purpose for them to be really fully vested and involved with the programs that Grace Hines was talking about earlier. Next slide, please. Other interesting findings from this study was engagement is very, very important to physicians, but there is a gap between what is important to physicians to feel engaged to what they felt that they were experiencing and what their ideal was. And that gap was fairly large. Administrators also, they found in this survey, when they gave it to administrators and to physicians, that administrators tended to overstate how well their organization was in providing what physicians actually wanted and needed. And finally, feeling engaged is a prime driver of physician satisfaction and dissatisfaction with their jobs. In other words, when they polled the physicians and asked them open-ended questions, they really responded and says, yes, if I feel engaged, I'm more likely to stay at this current job. Otherwise, if another opportunity comes, I'm more willing to move. Or when they were asked about recruitment, if they had a sense that there's good collaboration with the organization and the physicians there felt happy and engaged with their work, that they were more likely to take that opportunity as well. Next slide. So there are some barriers, and in my experience, and I just also started work at a new facility with my employment with University of California, Riverside, where the workload is fairly brisk and heavy. And interestingly, you know, when it's not just about seeing the patients, it's about how much time is involved with that. And to ask providers to actually go and do these other quality projects without alleviating that time and workload commitment, it's not going to go over very well. So when I went to this new job, I had to learn 3 different EHR systems within the hospital and the clinics, and it's quite an onerous task. And I've gone through 3 different major EHR installations at various facilities that I've worked with, and every time it just creates such a big burden on physicians to take care of their patients and get out in a reasonable time to go home to see their families and so forth. So if you're going to get physicians to be engaged, we have to understand the struggles of the physicians in their day-to-day practices and lives. Next slide. So another report by the Kinsey Foundation found 4 concerns. Patients feeling overwhelmed and ill-equipped to effect change, lacking the understanding of their part in the healthcare waste and inefficiency and what they could do with that, and hospitals and payers believing that employing physicians is a primary means of securing alignment, and organizations having the misconception that compensation is one of the most important drivers for physicians, and finally, physicians having a poor understanding of the risk-based payment model along with being risk-adverse. So the main findings here from what I read into it was that there is a lot of misunderstanding from the organization's perspective and maybe from the physician's perspective. They're really not understanding each other and moving forward together because there's a lot of uncertainty within the healthcare system and environment with the payment systems, and they don't have a clear roadmap on how to move forward. Next slide, please. So, developing an action plan. Let's talk about that. Next slide. So, I would suggest, and we did this informally when I used to work at Intermountain Healthcare, and also we did it informally again, and we utilized existing survey tools to actually query how engaged and how happy and what were the concerns of the physicians. You can use an online survey tool, very sophisticated tools, or you can use quite simple ones, which I'll share with you in the next slide. But after you get that, it's really important that you communicate the results of that survey back to the physicians, and then have meaningful discussions and interactions to discuss how we're going to change things and move forward so that we can increase this engagement. Only then really can you make change. Next slide. So a very simple survey tool might look like this and ask 6 very pointed questions. Do the physicians know what is expected of them at work? Do you feel that you have the right materials and equipment to do what you need to do to get your work done? Do you have the opportunity to do your best every day? And in the last 7 days, have you received recognition or praise for doing good work? Does my supervisor or someone at work seem to care about me as an individual, as a person? And is there someone at work who encourages my development? So these are essential questions that people need to be asking to see what the state of mind of physicians are. If there is something amiss, then that's something that you all need to work on. Next slide. So physician engagement really is an understanding and agreement on what really is expected. Both the hospital system and the physician and all the people that are surrounding the physician really are agreeing and understanding what needs to get done. It's also important to provide the right tools and support to allow everyone to do what they do best. So, for example, when I was at Intermountain Healthcare, there was a big program called clinical integration, which really was an experiment. And little did I know when they assigned me this task of being a medical director over the women's and newborn clinical program, that there were actually 2 other previous failed attempts in how to do clinical integration in a meaningful way. And being naive as I was and being a young, energetic physician, I was gung-ho about going forward and doing things. But they actually learned from their mistakes, and they provided the right structure and right support so that we had the right infrastructure developed to support not only physician leadership, but the communication pathway so that all the programs that we were going to develop, we had great interactions with the physicians at the local level, and we had clear plans and that they were participating in from the very beginning. We also need to have this a very good sense that we really care about physicians and that we're not imposing things on them because we're appealing just to their altruistic needs and saying, you have to pitch in for the good of the cause. We know that there's going to be significant impacts perhaps to your practice. We realize that, how can we make it work together? And of course, this cannot be overstated enough, is that optimal communication and partnering is essential. Next slide, please. So the do's and don'ts for effective engagement. And there are some things that simply just don't work. And productivity incentives, it's not going to work in the new environment anyway, because it's not about productivity. It's about improvement of care, efficiency of care. Speeches to inspire people, that only goes so far. Giving people appointments in leadership roles, particularly without the proper training and the proper motives and proper alignment and so forth, really doesn't work. And employment alone is not a panacea either, because physicians still, even if they're employed or not employed, and are affiliated with your institution, still need to know exactly what needs to be done, how to do it, and given the right tools and resources, and really understand what the vision is. And sharing best practices, we tried that before, and just the fact that sharing the best practices really doesn't work. And we've actually seen that in our work, where we can share best practices with our clients, with our work that we do on a day-to-day basis. But really, when we look at it, the best studies that are out there show that if you put the information in front of doctors at the point of care, educate them on how to use that information, that's the best way to change behavior as far as practice of medicine. Next slide, please. So what does work? Well, it's really about training and having and developing great physician leaders armed with the appropriate resources. So if you don't have somebody that's well respected, somebody that is aligned with what you're thinking and has respect of his colleagues, it's really difficult to move forward. And Grace previously said that in her talk as well. And it's really creating focus on a shared vision. What can we do together? If you don't have an object or a target to go through, and we're just dealing with the daily grind of patient care, that's not going to work either. It's to develop a roadmap together for improved engagement. It's time. So they have to know where they're going, how they're going to get there, but you really have to communicate that clearly and really act on it. Physicians' time frames are different than others. Physicians, particularly if you're working with a surgical field, the time frame is, I want it done yesterday. And if you're working with any physicians at all, they really want to see change happen in a timely fashion. So if months go by between meetings and no action takes place, then physicians are going to not want to participate because they don't want to waste their time. And it's really important for physicians to feel engaged at every step of the decision-making process. They just do not deal well when they say, well, this is what you have to do, and they haven't had any input on it, even if it is the right thing to do. It really is kind of interesting human behavior as it is, that even if you have come to the same conclusion, but they had a time to discuss it and were involved and had questions answered, it may take a little bit longer, but it actually makes the work a lot easier and you get to the target faster. Providing the effective training and resources is so important. One thing that I've learned over time was that when we put in a program in place, you take that extra time and energy to say, this is how the program works. For example, when we first set out the 39-week elective induction rule, one, we had to understand that there was a problem and communicate that to the doctors. Secondly, we had to use local information that was relevant to them. I could not tell them that it was good because somebody else said so, or that there were some studies that used a different population. I learned very quickly that our physicians responded well to our own data and information, and better if it was local and it was their own information personally and so forth. Once we outlined the problem and said, we were having issues with near-term babies ending up in the neonatal intensive care unit because they were delivered a little bit too early, and this is where their statistics were, and how they could be a part of it and what we needed to do. That program went forward, and we were able to reduce our elective delivery rate from 20 nearly 28%, down to today at Intermountain Healthcare, it's about 1% or less at most of the facilities and so forth. So that effective communication is so important, the training is so important. And have clear benchmarks and accountabilities for initiatives. So, for example, on that initiative, we actually reported back to the individual hospitals on a monthly basis. I made sure, at least on a regular basis, to touch base with the individual departments. And on a monthly basis, we made sure that we had a council with all the representatives from our hospital system so that we could make sure that all the information was being tracked back to the physicians and that their concerns were met. We always had balancing metrics to always consider their concerns. And if we needed to adjust the measures because there was a glitch in the system, which we had to do, one of the early findings was that there was a nurse-physician interaction that we didn't anticipate was going to be a major problem, but we found out that it was, so that we took that responsibility away from the nurse, and we said, that is clearly in the realm of physician communication for this to be successful. So the nurse was instructed just to deflect that and just say, you need to talk to the medical director or to the department chair or the director of labor and delivery, and that quickly handled that issue and so forth. And then applying the right compensation model to push the right levers. So again, you don't want to incentivize just for production, but you want to incentivize for right practice. This is still an unknown and uncertainty in this area where CMS is actually working on this and it's evolving. So more to come on that. Next slide, please. And if you have the system in place, that's great. But one of the interesting things there's some programs like at Geisinger that they really have a great program for physicians coming in. But nonetheless, these are some things that you should have in place just to make life bearable for physicians. Promote work-life balance with flexible scheduling, inclusive, because again, you have many physicians that are coming in that only want to work part-time, don't want to work full-time because there's family concerns, they're young in their practice and so forth. So that's something to consider. And offer competitive compensation. It's no good if you have a practice in which physicians feel that they're undercompensated, that they're compensated at the 25th percentile and so forth. So offer competitive compensation. Recruit for cultural fit. This is really important as well. Even if they're a talented person, they're very much top of their field and you think that you need that to start a program, if they're not a cultural fit, it's going to be very difficult for them to fit into your organization and get them to be engaged because they may be seen as a prima donna and eventually they may leave. So develop a physician-specific onboarding process. Many places have a short-term onboarding process, but I think what's needed is really a year-long process in which you have mentoring involved, that you have specific goals and metrics, that physicians feel that they're acculturated and so forth, that they're not being hazed by being dropped into a clinic or dropped into a situation in which they don't know how the situation operates and so forth. And really choose physicians, again, with the proper cultural attributes that really would promote your programs, are aligned with your culture, aligned with your vision, and have respect of their colleagues and can move forward. They're very open and adaptive. Next slide, please.
And Bryan, if I could ask you, we're about out of time, so if you could do the summary briefly, please.
Yeah, this is we'll just go over this last two slides. So physician engagement is a critical success factor, and these are all known things on these slides. So let's go to the final slide. So really, physician engagement is built on a culture of mutual respect and trust. And these are some of the things that you really need to provide for physicians. Taking care of themselves, time, financial security, tools, support, and clear goals and objectives. I know it's brief. I was going to put some more stories and things in there, but I think we ran out of time, so there you go.
Bryan, thanks very much. You had a lot of great illustrations and an excellent framework. think the two presentations together really emphasize the, or complementary, emphasize the importance of alignment. We talk a lot in this collaborative about financial models and adapting to financial models that aim to support better outcomes and lower cost. And what you've heard from the presentation today is a whole strategic approach to making sure that through physician engagement there is alignment with those, not only the financial models, but the support tools, the point of care assistance, the training, the roadmap and benchmarks, the recognition, everything that as part of an effective organizational strategy can get physicians working effectively in new payment and delivery models. We are out of time. There were a few questions that came in. We'll try to respond to each of those. One really quickly about the CPC Plus. There is no payback expectation for the upfront payments in that model, though you don't get the incentive payments, which are set aside in this bucket each year. You don't get those unless you meet the performance goals. But we will try to answer the other questions that came in. For right now, I'd like to thank again our presenters, Grace Hines and Bryan Oshiro, on the critical topic of physician engagement and leadership in the movement towards accountable care. And thanks to all of you today for joining us. Have a good rest of the day.